morning, everyone. This is Pratima Penumarthy, founder and president of Volunteering for Seniors organization, a 501c3 organization. Our mission is to reduce loneliness and isolation among elders and help them stay more energetic. We aim at making sure that seniors blend into our communities without any difficulties, and we are achieving this through meaningful volunteering. Since June 2021, we have been conducting VFS virtual webinars, talk shows, conferences for senior citizens, and keynote presentations, general sessions that completely focuses on supporting health, self-care for seniors and caregivers of older adults and individuals of any age with or without dementia all across USA. Today, our main topic we are discussing is speech therapy for adults. From time you wake up in the morning to the time you go to sleep at night, you spend majority of your day communicating. Whether it is through speaking, writing, reading, or listening, you are constantly engaged in activities that are linguistically and cognitively demanding. Speech changes in seniors can also occur in ways that are not directly related to the natural aging process. For example, what I know is that health conditions like Parkinson's disease or stroke and dementia can also bring about changes in person's ability to communicate. In some cases, certain medications or even an injury may also to be blamed. Speech pathologists are able to promote a healthy lifestyle for seniors, educating them and their carers on dementia-related conditions and how strokes may be prevented. It is important to establish that speech and language abnormalities are not related to factors that are, such as medication, depression, dehydration, so on and so forth. Speech therapy is often thought to be mainly used for young children developing their communication abilities. However, students and children are not the only ones that can greatly benefit from speech therapy. Friends, in today's conversation, we dive into why speech intervention for seniors is extremely important and effective in some instances. We have with us today Mala Sendil Kumar. Mala Sendil Kumar graduated from All India Institute of Speech and Hearing with her bachelor's in speech language pathology and audiology. And then she pursued her master's in speech language pathology in Ohio University. She had worked actually in the capacity of medical speech pathologist for almost 30 years in all kinds of settings, ranging from ICU, ventilator hospitals, long-term nursing, and skilled rehab facilities. Her clients, they have a wide array of medical diagnoses, and she has worked primarily with patients with neurological deficits such as Parkinson's, MS, ALS, strokes, etc. Besides working with adults, she also has a fellowship in infant parent mental health from UMass Boston, and she's presently pursuing her master's. We're very happy here today to have Mala Sendil Kumar with us. Welcome, Mala.
Hey, thank you very much for having me and giving me this opportunity, because I think education and educating is, like they say, knowledge is power. So if we empower the senior citizens with knowledge on how to prevent or what's going on and how they can get speech therapy, what services they can avail, I think this is a very good opportunity, and I really want to thank you for letting me come on your program.
Thank you, Mala. So we have a number of questions to ask you, and as the time permits, we can keep on asking you more and more. And again, I'm telling this to all the viewers that even after watching this wonderful show, if you have any questions, please feel free to ask your questions under the comment section. And when Mala gets time, she will respond to each and every one of you. So the very first question for you, Mala, is that, this is a general question which most of the caregivers, they keep asking, and, even in the support systems, as to why speech therapy is important for seniors.
So I'm going to share my screen right now and just introduce you to speech therapy. So you can see that a speech therapist is just not a speech therapist, but we also work with swallowing disorders, which in the long-term setting is our primary diagnosis that we see a lot of. We also work with memory-related disorders. We talk with, we work with speech-related issues, language-related issues, and voice-related issues. And I'm going to explain each category so you can understand it better. Dysphagia is another medical term for a swallowing disorder, and it can occur. I'm going to later on say what the different underlying pathologies are that can cause dysphagia or dementia or dysarthria. But this is just a general introduction to speech therapy, so I'm going to keep it simple. So dysphagia is, you can have any trouble. Phagia means swallow. Dys is a disorder of. So from the Greek root, dysphagia means anything that, any problem that is caused in the swallowing mechanism. So you can have the swallowing disorder not only for neurological reasons, it can also be because of anatomical reasons, when they have tongue cancer or any kind of radiation, or there's a abnormality in the speech and the swallowing structures, such as the tongue, the mouth, the larynx, which is a very important thing for swallowing. So a speech therapist works with swallowing when they also have a G tube put in their stomach for nutrition for different reasons. And when a speech therapist is going to intervene, our goal is to wean off the patient from the G tube and get them to eat again. And the G tube can be for a variety of reasons. And then we go in and do an assessment and decide if that person is safe to eat. And then we'd start doing therapy. And like I said, it's a whole complete half an hour minimum education thing. So I think if we have the opportunity, it would be good if we can address each problem in its specificity. Right now, like I said, it's just a general orientation. Dementia is, I think, what many people are interested in because they wonder if they are losing their memory and if they're going to get dementia. That's something that is extremely predominant in people's minds. But sometimes we all forget things. So the question is how much is abnormal and when should you start to worry? So again, we do a cognitive testing, and we test seniors by sending them back home. Before we send them back home, we see what kind of deficits they have and what kind of support system they have. So I consider each individual as unique and under unique circumstances. So I cannot blanket everybody into one category. So I make sure that every individual or person I meet is got unique circumstances, and I go from there. You cannot, so you could have somebody who's got severe memory deficits, but they have a really good support system, then they can go back home. Or you might have somebody who could be independent in every way, but they just might have forgetfulness for a few minutes, but that can put them in jeopardy if they're living alone. So each case scenario is different based on their circumstances. Dysarthria is a disorder of articulation, and that happens primarily with neurological disorders like Parkinson's, when they slur their speech and they are not able to clearly speak. And the dysarthria is easily compared to aphasia, which is a language disorder. And language is the way you put your thoughts together, but speech is only one method of communicating your thoughts. You can write it down, you can sign your thoughts and get your feelings across. So speech is only one avenue with which you're expressing your needs. So if the language itself is broken because of a stroke or a head injury or different reasons, then the ability to put words together is impaired. And then you have something called aphasia. And in that case, their speech might be well preserved, but what they're saying they call it a word salad. So it might not make sense at all. They might say something like, oh, the dog was the drinking tomorrow is after all the beautiful. And the intonation is correct, the words are correct, but there's no meaning. So that's a language disorder. So their speech is good too, but it makes no sense. So we have to diagnose if they have only aphasia, or they have aphasia and dysarthria, or they have all four: aphasia, dysarthria, dementia, and dysphagia, which is very unfortunate. And I deal with dysphonia, which is voice disorders, very, very rarely, because because of reimbursement, which we'll talk later. But in voice is usually affected when they're intubated after surgery, and most of the times it comes back spontaneously. But sometimes they can have vocal fold paralysis when we do therapy, and I have to address it as a like a therapy because of a paralyzed vocal fold. So that's when I deal with dysphonia. So this is what we do in a speech therapy.
Yeah, it's wonderful, Mala. You gave a very nice descriptive information. A part of this question, I know you have already explained this, but so what does speech therapy do for the elderly? I mean, I know even though you explained all this thing, what does it actually do for the elderly?
So speech therapy is different from physical therapy and occupational therapy because the incidence of anybody needing physical therapy or occupational therapy is 1 in 1. Like everybody, 100% of us could need physical therapy. So you could fall or sprain yourself, and anybody can need physical therapy or occupational therapy. But speech therapy is needed only in the presence of a disability. So if someone is not ill, they're not going to need speech therapy. So unless they have a medical disorder that is contributing to one of these impediments, they will not need speech therapy unless something is wrong with them. So I am not able to practice preventative speech therapy. So I can only educate in seminars like how you're giving me the opportunity to see if they can prevent memory disorders. But if they do have a dementia, only then I can go in. I cannot go in the absence of a pathology. So it is therapeutic, meaning a therapy is to rehabilitate something. So in the absence of a disorder, it cannot be therapeutic. So I cannot do anything preventative. It has to be therapy in the presence of a disorder.
Agreed. Makes sense. And then Mala, what are the common speech disorders that you must have noticed, among adults that do require speech therapy?
Like I said, these are the main things in adults. Only when they have head injury, I can show you different types of the causes of speech disorders, like what can cause speech disorders. So if you look at the pathology or the pathophysiology of what causes speech problems, the primary problem is neurological, which is because of any kind of nerve damage. And you can have strokes, which can cause aphasia. So everybody knows a cerebrovascular accident, or CVA, is the medical term for a stroke. And it can also be a TIA, which is a transient ischemic attack, which means it's transient. And transient means that it's almost like a light is flickering and then it gets the connection back. But the flickering is a warning sign that something is impending. There's an impending hazard of getting a stroke in the near future. So when you get a TIA and you get a slurred speech and you feel like you're searching for your words, that's all. And they all just say drooping on one side and other physical things like weakness and numbness in your extremities and all that. Those are warning signs for a stroke. So you should not ignore any of those when you're coughing a lot, or you feel like you have difficulty swallowing, you can't find your words, you have slurring of speech, you have numbness, unilateral weakness. All these are signs for us. If they're getting it and it's going away, you have to go to the hospital right away, because they have a window with which they can give a specific treatment. And we will talk about that medical aspects later when we talk about aphasia, if you want to talk about language. But if you do not go within that window, your prognosis is going to get poorer and poorer as the stroke progresses. and the damage to the tissues is extensive. So you want to go, as soon as you get a TIA, you want to address it medically and go find out and tell your primary care that you had such symptoms. You do not want to ignore such symptoms. TBI is a traumatic brain injury, and it's also, they call it closed head injury, a CHI, or they can call it an MVA, a motor vehicular accident. Medical fields have so much acronyms, and what's an acronym for this field is not for the other. So there's lots of acronyms here. And spinal cord injuries or seizures, these are all causes for speech disorders where they can have aphasia or dysarthria. Neuromuscular disorders are diseases, okay? So they're considered a disease versus a stroke is an acute incident, and it can be caused because of coronary artery disease, can terminate in a stroke, but it's like a disorder compared to a neuromuscular disorders are like a disease progression. So like Parkinson's, MS is multiple sclerosis, ALS is amyotrophic lateral sclerosis, and myasthenia gravis. These are all disorders where the muscles get weak, supranuclear palsy. So what happens is everything has a different pathophysiology. The myelination gets, there's degeneration of the myelin sheaths, or there's degeneration in the synapses, and the serotonin in Parkinson's, there's lots of the treatment options are different for different diseases based on what is causing the speech disorder. So if you say, oh, my speech is slurred, and you go to the doctor, they're going to run an array of testing to find out what is causing the speech problem. And then if it's Parkinson's, your whole treatment options are different. And for ALS, it's different, and so on. But we treat them all based on the symptoms. So I am having in the back of my mind, I'm like, okay, this is what is happening. And the speech, and again, just based on the speech, there is something called flaccid dysarthria, where everybody is like just a little weak like this, or it can be tight like this, that they cannot talk. That's called spastic. So depending on what kind of speech disorder, we know if it's in the upper motor neuron or the central dysarthria, or it's in the extremities or happening in the lower motor neurons. So there's a lot of testing that we can give to the physician and tell him we think this is what is happening. Even with strokes, we do a lot of testing. So we are the ones who identify left-sided neglect. And there's a whole array of problems called the agnosias, like they cannot recognize the face. It's called prosopagnosia. And lots, it is very interesting when if I'll do a stroke presentation, it's like the terms, there are at least 25 different terms, and it's very interesting. Now you have, the next one is metabolic disorders, which is reversible. So everything else was not reversible, but the metabolic disorders are reversible or infectious diseases. So somebody has confusion. So an elderly person is exhibiting confusion. They have to figure out if there's a urinary infection going on. And they're going to act like they don't understand. They're going to act disoriented. And you're going to think, oh my God, they're getting dementia. But actually, you have to take them to the hospital. So the first thing they'll do is run lab work to make sure the potassium is good, their sodium balance, everything is all balanced. And that's called metabolic encephalopathy. And again, in that case, speech is not involved that much, because once you fix the metabolism, it's going to fix itself. So it's a reversible disorder. So you have reversible, most of the dementias are irreversible, but then when you have memory problems that are reversible, then you're fortunate. So it's our job to find out if they're having an issue which is irreversible, which is going to deteriorate, or it's reversible, which is going to be remedied or can be rectified with intervention. And I'm not going to deal with congenital disorders because that's from childhood. So it's not an adult thing. So it's like Down syndrome and all those, autism and all that. And speech therapists work with that too. Speech therapists work like in 5 or 7 different settings. And each setting is so niche and so detailed that I cannot just, I can practice speech therapy as a whole, but we all know the limitations of our scope of practice, because we need to be qualified in swallowing disorders. I need to be qualified for a modified barium swallow, where we work with the radiologist to see how they swallow and do X-ray studies. And then they also have endoscopic studies that speech therapists do, and they're all like 3-month training. So I'm not trained in some of those. They have trainings in ventilator related hospitals. So they're all, and then they have something called pediatric dysphagia, which is only for preemies and swallowing. So we have such really detailed practice that we do.
Actually, Mala, you have explained many things, which was a part of my questions, but you already explained what are the diseases, what diseases even cause speech problems, and also like what does speech therapy involve, which you have definitely explained. Is there anything else that you want to add? Like if it comes to specific, like what does particularly speech therapy involve?
Yeah, so look at this next slide, which says, once we are involved and we know there's a disorder, then the physician gives a recommendation. We cannot see a patient unless, like a PT order for a physical therapist, we still have the same requirements for speech therapy you need to have. And I don't do private speech therapy, so it's all a different ball game. I work in the hospital, then I just go with the protocol that the hospital follows. And even in the hospital, the doctor is at the top of command, and we report to him and give our findings to him. So we all work as a team, because honestly, even the CNA could be one person who's like, oh, he's been drooling from the right side, and because he seems like he's okay, so he's in the hospital, they're monitoring him. The nurse comes and takes his blood pressure and says, hey, everything looks okay. But only the CNA sees that, oh, when she comes to this side, he's got like something drooling from this side. So she can report it to the nurse. The nurse will report it to the doctor. The doctor will ask us to go and see the patient. And it can be anybody. So our team comprises of the doctor, the nurse, so the whole nursing staff, including the CNAs, the social worker, and the physical therapist, occupational therapist, and the speech therapist. We all are a team, and we have meetings once the patient is in a treatment. But the minute I get a referral from the doctor, I go and do a chart review to see what the history is, how acute the problem is. So some people might come back to the hospital, but they might have had a stroke 2 years ago. So I know that it's not, in my mind, I'm like, okay, this is what I have to expect, because after 2 years, if they still have a speech problem, I know that the prognosis is what you see is what you get. But what I've learned is never say never. I always give hope, because like I said, I always believe in miracles and giving hope. And you can never say that, oh, this person is never going to improve. I would never, ever do that to a family. And sometimes I know it's very, the situation is very dire, and that person is not going to make improvements, but still it's not my call to tell that he's never going to speak again, Yeah. So I'm hoping that someday that something will click. And I do have a patient after 2 years of not talking, she's talking now, and we really do not know, but not talking a whole lot, but she's slowly starting to talk. It doesn't make sense sometimes, but sometimes makes complete sense. And we are amazed at, wow, what did we do there? She got like shingles, and they gave her some medication for shingles. We're like, is this helping her with the myelination, with the connection? What is that what made her talk, or is it psychological? Was it some kind of depression, and now she's interacting more, so she wants to talk more? So you never know the underlying reasons why someone is going to show improvement, but you always want to do your best. So you got to keep at the therapy. So when I go in, I do the assessment first, and in assessment, I do a whole standardized test. So we have testing for swallowing, we have testing for aphasia, we have testing. So it's I do not know if you've heard, many people might have heard about the mini mental. So it's a very simple mini mental is, do you know where you are? Do you know who the president is? So a simple thing. So we do a glorified whole cognitive assessment, and it's almost like neuropsychological testing, which is very detailed, and they're very specialized. And I love neuropsychologists because I can really learn a lot from the neuropsychologists and what they do. So based on my chart review, I'm like thinking, oh, maybe this person could have dysarthria, maybe they could have dysphagia. So I go with all that in my mind. And I also believe in taking an extensive history from the family, because the patient could give wrong information. So you want the family members to say this is what happened, because the patient might be confused and you cannot take the word for it. For whatever reason, they might be tired and they might not know what they're saying. So I always try to get hold of a family member to ask, is this something new that you're seeing? Because let's say they have not had a good memory and they're relying on other people for like 5 years. They do not know the family members' names. And I go in there and try to change it. I'm not going to change it after 5 years. So I need to know how long this is going on. I need to form a prognosis in my mind. And after the assessment, I give a diagnosis and I say, this person has unilateral vocal fold left-sided paralysis for boys, or I could say he has moderate to severe fluent aphasia, which is a type of aphasia. Like I said, once we start talking about each thing in specifically, you'll understand more. So every diagnosis I try to give is the severity of the problem and what area the problem is. So is it a swallowing disorder? So it could be moderate, severe, oral phase dysphagia, or is it more like a pharyngeal phase dysphagia? So I tell them exactly where it is and the severity of the problem and the diagnosis. So I could say moderate dysphagia or moderate aphasia or severe this, or, so I have to be very specific when I give that. And based on the diagnosis, I then come up with a treatment plan. So that's like how we have an IEP in schools. I have to have a treatment plan with a long-term and a short-term goal. And again, my goals differ on if it's outpatient, I'm thinking different. If it's acute care, I'm thinking different. If it's ICU, I'm thinking different. If it's a sniff, I'm thinking different. But I'm always thinking I'm going to get them better. That is the constant, though I'm thinking differently. The one thing that is constant is that I'm going to help them get better,
So, Mala, would you explain to me what is a sniff and you just mentioned now?
Okay, so a sniff is a skilled nursing facility. So usually I've been doing this for so long that in those days, they thought that once somebody went to a nursing home, which is a sniff, a skilled nursing facility, they thought that they would be there forever. That was the end of their life, But now it's become so different. There's patient advocacy. So they always believe that a patient is going to be happiest in their home environment and their surroundings. So unless they are really compromised medically, we try to send them back home. So even though they're in a skilled nursing facility, we always have one kind of unit which is only for rehab. And we have people going home in like 2 weeks, 3 weeks, like constant flow. And then we also have the long-term unit where there are patients who do not have the support at home and they are considered long-term care patients. So, and then there's also something called LTAC. So it's long-term acute care. So this long-term sniffs that I work in they need some help from the nurses. They need medication. But they're not like acute care, like on ventilators, and they're not very medically compromised. So there are one or two very special places called LTACs. So they are for people who are more medically compromised, like almost like an acute care hospital, but they're long-term. They're going to be there for a long, like probably forever, like chronic. So those are called LTACs. So once I'm going to tell you the hierarchy of how it goes. So you go to the ICU.
Yeah.
ICU, from the acute care, you go to the acute care of the hospital. So you stay in the hospital. From the acute care hospital, they could send you to the outpatient rehab in the hospital itself, or they could send you to a long-term nursing, which is a step down before they go home. So once they go to the acute care hospital, the doctor says, you know what, I think you need some therapy. You need like at least a month to get better before you go home and live independently. So he sends them to a sniff or an outpatient, depending on what their circumstances are. So once he sends them to a sniff, even within the sniff, there's LTAC, like I said, depending if they're very compromised, they have to go to a long-term. And the sniff, we have the rehab unit. And then when we do a discharge planning, there's the last thing I said is caregiver education. So we involve the family and say, this is the deficit. This is what he needs. This is what you need to provide for the patient. Because if you are going to send him home alone, you have to remember that this person is at jeopardy of doing something dangerous, and he could come back to the hospital again because he could miss his diabetes medication, or they could just get disoriented and wander away. So we have to make sure that we educate the caregivers and tell them, what this patient is capable of doing. And then we allow the family to decide based on the support system. And then we all sit down in a discharge planning meeting and discuss what's best for the patient. So,
Excellent. There's a lot to learn, Mala, in this. In fact, each part,
yeah.
now just writing about when you were explaining about this, the acute care, from there, you mentioned they go to ICU, right?
So
And
from
then
ICU is the highest, then they go
the highest, and they go to acute care, and then they go into the outpatient, or that's the LTN, right? From there, they go to
SNFs, like nursing
yeah,
homes.
or so it's a long process. And the question that comes to my mind is coming to billings, and of course some of these seniors that we've been taking care in our organization, most of them, actually 80%, have Medicaid. And
So
some of them who approach us, they have Medicare. Now, people who have Medicaid, we saw that most of these things are covered for them, for Medicaid, when they are on Mass Health. Like in coming to our state of Massachusetts, most of them, they have this Mass Health standard. But what do you think is that, does Medicare pay for voice therapies?
So I think I forgot this. This is the settings slide that we talked about before I came to the slide. So it says ICU, acute care, rehab hospitals. So there's specialized hospitals like Spalding Hospital.
Yeah.
And then there's Braintree Health South Rehab. That is only for rehab. So they're only for physical therapy, occupational therapy, and speech therapy.
Oh,
so
that's again for the viewers to know that Spalding, what Mala is explaining in Braintree, this is all with respect to our state of Mass.
Yeah, Massachusetts.
Massachusetts, yeah.
So they have specialty hospitals, which are ventilator hospitals. So you could have just catering to people with pulmonary problems, So then you have outpatient care, and then you have SNF and rehab care. And I did not mention the last one, which is the assisted living facility.
Right. Yeah.
Which is like, it's almost like living in an apartment, and they have the independence and everything, but they have the support.
Because that's where we help a lot of seniors, and we've been seeing many seniors there who are actually undergoing so much of speech therapies too. Yeah.
They can, but assisted living, because of the independence, there's amount of speech therapy is limited, because I can give a lot of speech therapy in the nursing and rehab setting compared to ALF, which means they're more independent and in the community. So the frequency of the treatment gets reduced. So talking about reimbursement, I am actually not, I can give you the information as much as I know, because I've never done private practice, but I always, like how if you work in a hospital, your billing department does everything for you. So the information I know is, as soon as somebody goes into the hospital, Medicare A kicks in. So they have a certain number of days, and then the Medicare A, it depends. Earlier, it used to be like they could get so much minutes of therapy and 7 days a week, and it used to be covered. Now they have moved from a PP, prospective payment system, PPS, to a PDPM system now. So it's the PDPM system is like a patient model. So they say that the patient is patient driven. So I think it's called a patient driven payment module. That's PDPM. So now Medicare A, so the nurse tries to see what the diagnoses are, and based on the diagnosis, speech therapy is approved or not approved. But I have always been lucky enough, if someone needs speech therapy, my building I work in a skilled nursing, and every different skilled nursing I've worked in has been different. Some places will deny and say, no, Mala, you can't see them more than this much time. And some places will be like, you can see them. So I think it's like the squeaky wheel gets the oil. So I think if you really fight for your services, you might be able to get. But again, the insurance manager is God, so they decide how much it is to be given, and I go from there. So Medicare B is, unfortunately, what happened was, when Medicare B yearly annual payment that they allocated for therapy was written out, they forgot that there was something called speech therapy. The
oh, that's so sad.
The CMS, the Medicare services, forgot that speech therapy existed. So what they did was, they had to bundle it with physical therapy. So occupational therapy gets, I think, 1,500 a year of therapy services, but PT and speech together get 1,500 now. So just because they forgot that something like speech, I can
PT and speech therapy, it's like 500.
1,500 a year.
1,500 a year.
And occupational therapy is 1,500. So this is, I'm everything else I gave you clinically is 100% knowledge. I can back it up, but this one I'm a little not sure, but this is only what I know. And Medicaid, again, is Mass Health in the state of Massachusetts. They cover a lot of devices. So anything that Medicare doesn't cover, Medicaid bills picks up the slack. And I can get like augmentative communicative devices, like how Stephen Hawking's uses the Liberator. It's called a machine that talks for him. So I have been instrumental in obtaining devices for my patients who have ALS and cannot talk anymore. So then I have to go through a whole trial basis. I get a device and I give them the trial and I see how they can use it. Then I have to give them the documentation and send it back to Mass Health. Then they provide the device. Or sometimes they might also have spare devices for artificial larynx. When they don't have a voice, they put the voice here and it makes a voice for them. So they have some devices that they can send to a person in need for a trial. So you don't have to wait and pay $8,000 for it, you know. So you can do trials things with the help of your speech therapist. You can ask for devices, and usually the devices right now are limited to augmentative alternative communication devices, which is called AAC devices, which little children with cerebral palsy, like lots of kids who have developmental disability and who are using switches and they're nonverbal. They use the AAC devices, and they use lots of apps now on the iPad to communicate. But we also can use that with the elderly. We use a lot of apps, so they can get it from Mass Health, can see. And then private insurance is a lot of now. I'm dealing with private insurance B, which is like that insurance is like an agent, I think. So they take the patient and then they are in charge of the patients. So we have something called Senior Whole Health and Tufts and all that. So we also see private insurances. Sorry, Pratima, this is
nice, because this itself is very, very informative, because a lot of people, who are on Medicare plans, Mala, they're pretty confused. Because though they call and they get information, when it comes to Part A and Part B, it's a lot of mess.
I think it is the same with any medical thing. I would really recommend that they call their insurance and they also call the provider. Both.
That's what they're doing. But what happens is that when, like, for example, when I was listening to you, there are so many divisions, like, that's not like everyone comes into one line in therapy, right? There's so many,
yes.
Hierarchies that happens there. So when these things are happening, and again, everything requires billing, if there's some plan like Medicare, which covers up and where 20% is paid by, of course, 80% is paid by their, whoever is their network, and then 20% they pay from pocket. I have actually heard from some seniors, Mala, where even the 20% becomes too much on their pocket.
Yes.
And
so I think Medicaid, what I've seen so far, and the social worker talks to my patients, Medicare B takes 80%, and then Medicaid or Mass Health kicks in and takes the rest of the 20%. But my personal
that's what I want to tell you is that Medicaid, unfortunately, not everyone gets. Because Medicaid, again,
that is why it's a unique scenario. Because
it is a very.
I had to have an MRI done, and I called the MRI and I said, "This is my insurance. Is it covered?" And they said, "Sure, you have." And I said, "If it's going to have a lot of copay, I'm not going to get this procedure done." They said, "No, the copay is $300." And I said, "Okay, let me get it done because I needed the MRI." And then I get a bill from the hospital saying the MRI office is different from the hospital. So I get a hospital bill, and then I get a bill from the doctor who read it. With all this, the MRI office did not tell me. So they're all like, it's not like double dipping, triple dipping. It's just that they're not informing the patients beforehand. So my advice is, do not seek any services taking for granted that something is going to get paid. Record that conversation if possible, or get the name and whatever confirmation code that you talk to them. Get the agency's person's ID number, so you can say, "Hey, listen, I'm very apprehensive about me getting a bill later on, so I want proof that I talked to you people. So I need to have." So I'd really recommend that they do all that and not take it for granted that these services will just kick in.
Yeah. That is itself a very big topic, about the billing of how patients are billed in every department in healthcare
I
industry.
can I can actually get a speech therapist who does billing for seniors. So that might be a good
Excellent.
resource for you to have a talk with her.
Oh, thank you so much, Mal. That'll be really helpful because I know there's so many caregivers and who may need eventually down the lane too, even though they are caring of their loved ones too. That'll be a very big resource if you can give. Now, the entire this conversation, Mala, brings to one biggest question, which is what is the biggest challenge of being a speech pathologist or being a speech interventionist? What are the challenges that you face?
Um, I think the biggest challenge I would face is fighting for insurance and advocating for my services. The other thing is dementia and memory deficits are a very fine line with insurance companies.
Yeah.
So they say that if something is irreversible, what is therapy going to do? You know that dementia is deteriorating memory. So how are you going to help them? And I know there are places that would advocate for memory therapy forever. And I am not one of them. I actually would do therapy only if I can see some kind of we have to document that there's progress. And my biggest challenge has been educating even my own team members that I'm not going to help all the time. So I don't believe that I'm going to help every situation. And for me to advocate is actually advocating against myself, not for myself, that don't make me do therapy when there is no need to do therapy. That's been one of my biggest challenges. But I will help the family and educate them. So I believe that. So what happened was when people started to do this memory therapy, the CMS and Medicare said, we do not want memory therapies to be done by speech therapists anymore. So now they completely denied it. So the minute they see memory therapy, the code for it, they just deny it, and it's a blanket denial. And I am like, guys, it is not all or none. It is, some people have abused it in the past, meaning some therapy companies have abused it in the past, does not mean that everybody is going to be abusing it, because this person needs memory therapy for cognitive therapy because they have a head injury.
Right.
So that has been my biggest challenge, is to educate that. But even now I have doctors who will just say no to speech therapy because they don't think speech therapy is needed. So they make the call. So I feel I need to have that kind of education. But sometimes it's like it's like hitting yourself against a brick wall. It's not going to work. But then I ask the families to advocate for themselves. But I'll only do that if the patient needs therapy. I'm not going to ask them to advocate when there's no therapy needed. And if the prognosis is poor, I would not ask them to advocate for my services. But if I feel that they need it at least for 3 weeks, at least for 2 weeks,
True.
where I can at least educate. If I'm not giving the therapy, I will educate the family and tell, this is what I do, extrapolate it and do this for 5 months. And then just come back after 6 months for just one more visit with a speech therapist. So they can set you up depending on, they'll just do an assessment, reassessment, and see if there's improvement. They'll give you more challenges, or if there's status quo, they're going to be like, depending on what they see, they can make further recommendations. So I've always given like written homeworks and resources so the families can work without me, because honestly, at the end of the day, you want to help the patient get better. That's the main thing.
True. And I also feel, because you have such a very empathetic person, and I was thinking all the patients who've been with someone like you, Mala,
Thank you.
they must have gained a lot in their life. And if you could share with our viewers one or two examples of your personal relationship when you talked with them and the feelings you get, because to being with seniors, I mean, you've been doing a wonderful, knowing unknowingly, you're doing a wonderful volunteering service. Being a speech pathologist and being with seniors and being so connected with them, it's a very big, it's a big world all by itself, when
Yes.
you spend time with them. Could you just give, in just a few, in few sentences, or just explain to us your feeling that comes out when you take care of seniors, just being a speech pathologist and the relationship that you have with them?
I always tell my students who follow up with me or anybody, if you do not have the compassion, don't come and do therapy. And empathy is actually, it's a very difficult thing, but I think I'm blessed that every patient I see that person as my family member. And that's why most of my patients are still will be in touch with me, because they're appreciative. And I honestly am so blessed that I get the opportunity to make a difference in each person's life. And I honestly, Pratima, every single time I see a patient, I just go there with 100% devotion that they will get better in whatever way, and I want to make a difference in that moment and that in their lives. And I'm so blessed that every day, family members, even this afternoon when I came from work, family member was crying and saying thank you to me, and I think that is the greatest blessing, when they get tears in their eyes and they say thank you for being there for my mother, or thank you that, because they feel guilty. Most of
Yeah.
the family members feel guilty that they're working and that they're not there, and put their mother in a nursing home or their father in a hospital, and they're like trying to come from work, and there's a whole thing about caregiver stress,
Yes.
especially chronic illness, and how thin they're spread so thin that they are so grateful for every small help. And I have lots of wonderful experiences where someone holds my hand and says thank you, and I think I'm happy. My life is made when someone says that to me. Yeah.
You're very fortunate, and I think also those patients are very fortunate to have therapists like you, Meena.
Yes. Thank
Mala. And I have I just wanted to, because it was a wonderful conversation, just talking, and I didn't want to end this. I'm just trying to look at the time.
you.
Honestly speaking, today's conversation, I really didn't want to end,
Thank
because
you
I
so much.
learned a
Just let
lot, and
my, yeah,
I
just
still want to, continue and continue. And this is not the end, Mala, because I'm pretty sure we'll have many such webinars, and we'll have presentations where we would love to we would love to have you and discuss about certain topics related to dementia patients too. But I think what I learned today, just listening to, is that the goal of speech therapy for seniors is to increase functional communication, cognitive
functional.
skills.
That's an extremely
So
important word for us in therapy field, is
yeah,
functional, because I can't improve them and improve their speech and make them say 1 2 3 4 5 6 7 8 9 10. You're
yeah,
like, okay, they can't keep saying 1 2 3 all the time. How are they relating it in everyday life, and how to make it functional? So we have to have functional goals. If you don't have functional goals, it's not, our therapy, we're going to get denied by the insurance
mhm,
services. But like you said, each field by itself, I can educate so much more on just dysphagia or aphasia or
yeah,
dysarthria. So if you want to talk about it, I'm really willing to.
absolutely. There's a lot to learn. As I was telling you that, as you mentioned, one is to increase functional communication, cognitive skills, and seniors teach, as you were mentioning, about safe swallowing, by even introducing diet modification. And I mean, that's what even I learned, when things were done for my dad, diet modifications and special feeding techniques. But, there's such a wonderful, we had a presentation and talk today. And in conclusion, I would like to say to all the viewers that speech therapy for seniors is often necessary when recovering from the, as Mala was explaining, from the, what do you call that, the debilitating consequences of stroke or dementia. Um, it may be necessary even after a head injury, because I've seen so many seniors, walking and then tripping and falling down.
They
So
do need it. Very important after heading
yeah,
in.
and the ability to communicate effectively is important, honestly, at any age, but for seniors it can be absolutely vital. So with my little experience and with a lot of experience, what Mala has is that if a senior cannot successfully describe what they need, where they are hurt, or what is wrong in general, an emergency can easily occur. So talking about even basic conditions, sometimes we all know can be challenging for aging people and also for their caregivers. It doesn't have to be. As explained today, speech therapy for seniors can help them relearn how to speak using vocal exercises to help them communicate. That's another part which, if you had more time, Mala would have explained more about, what were the exercises that would have helped them communicate effectively, through the entire process. I would like to personally thank a lot to Mala. And at the same time, I would like to just tell again to all the viewers that please make sure to tune in to our YouTube channel, subscribe, and listen to such, wonderful talks or different talks about, we need today about what all we can learn for helping our loved ones, letting them grow older with dignity and independence. Without fail, I just do want to mention that please don't forget to join our VFS webinar, which is planning for Medicare, countdown to 65, that we are going to talk with William Rowbottom on July 17th at 11 a.m. So thank you again, Umala Sandal Kumar, to be with
My
us and
pleasure.
share your wonderful knowledge with us.